befitting to this discussion would be for us to look at what is evidence-based emergency care. And I think one of the key things for me is trying to identify what's the difference between what we do and witchcraft, okay? For sure, there has to be a difference between daktari kutoka which part of the world, I don't want to say which country, but we've all seen the posts and what scientists do. Because I find a lot of times we do not necessarily know why we are doing what we are doing. And many times when I engage with colleagues about the science behind whatever they're doing, then many may not actually have that science. And a lot of practices that are potentially outdated still get done, yet the science has shown that the practice is not there. So theoretically, when you do the same thing over and over again, you expect the same results. And so it's the same thing which witchcraft and which doctors do is they'll do the same thing. And sometimes you're in luck, sometimes you're not. So this presentation is to highlight what is evidence-based medicine. So we discuss what is evidence-based. What does the word evidence-based mean, and how does that correlate within the context of emergency care, and also look at some of the guidelines that we produce at the foundation that we use and disseminate across the country, and the evidence behind some of these guidelines. So it's a quick presentation about what is evidence-based medicine.
Hey, welcome to Sketchy EBM. I'm your host, Anthony Crocco, and today we're actually talking about what is evidence-based medicine. It may have occurred to you at some time or another to ask the question, what do people mean when they say EBM or evidence-based medicine? We hear this term thrown around all the time, and there's a number of different ways to think about the definition. One of the first things that people think about when they think of evidence-based medicine is it must mean the research, the actual evidence that's out there. What you'll soon see is that this is very, very limited in its definition and does not encompass all the aspects of evidence-based medicine. A second thing that comes to mind for some folks is the EBM pyramid. You may have seen an iteration or two of this, and usually at the bottom there are things like case reports or expert opinion, and at the top are things like systematic reviews, meta-analyses, or N-of-1 studies. Sadly, the pyramid in of itself is only a rank ordering of the different types of evidence, and unfortunately is very limited. So let's then talk about the different components of evidence-based medicine. Most folks would agree that there's three important aspects to considering decision-making when it comes to healthcare. The first thing is the evidence itself. We're not going to get away from actually getting our hands dirty and looking at actual papers and research and numbers and data. We have to know what's going on in the research. A second consideration are the patients themselves. Each patient comes to the table with a different set of values and preferences. What works for one patient may not work for another, and we have to think about that when we're looking at the evidence and trying to incorporate it. The third and final component is us, the clinicians. Who I am, where I work, and the experiences that I've had may be very different than yours, and how I apply the evidence to a specific group of patients, therefore, will be very different. Where we see these three things intersecting, the evidence, the patient values and preferences, and our own physician judgment and experience, is generally what we like to call evidence-based medicine. So I hope that helps you understand what evidence-based medicine is. Before we go, however, I think it's worth answering the question, are there any risks associated with evidence-based medicine? I would argue that there are, in fact, at least three. Firstly is what I would call evidence-based paralysis. You may have had this experience before where you have a clinical question, you go to the evidence to look for the perfect evidence, and lo and behold, it doesn't exist. After this, much dismayed, you're left with no answer at all, and therefore paralyzed in your decision making. One of the things with evidence is that perfect evidence. If you find some, let me know and message on Facebook because, gosh, I'd really like to see it. What we have to deal with is what's the best available evidence at any given time. And sometimes the best available evidence may just be expert opinion. A second major risk with evidence-based medicine is being taken in by the latest and greatest research and changing your whole paradigm of treatment based on one new study. I think it's really important to take a look at all studies that are done on a topic, and for this reason I really like looking at systematic reviews because they do just that. As a good friend of mine says, always be skeptical of anything you read. A third and final risk of evidence-based medicine is becoming what I would call an EBM a-hole. We have to be careful when we know of great research not to alienate the very people we're trying to teach with our way of presenting that research. Who you are, where you work, and who you treat may be very different than the folks that you're chatting with, and as such, the evidence may mean something different to them. Well, I hope that clarifies for you what EBM is all about. Thanks a lot for joining me on this episode of Sketchy EBM. Please do take the time to evaluate this episode, and until next time, always remember to draw your own conclusions.
What does that actually mean when you're on the ground and you're managing a case or managing a patient? So they're what we call the 5 A's of evidence-based medicine. And it always starts with, you've seen a patient and you figure the patient had a certain diagnosis. So what is wrong with my patient? Okay, so that would be asking the right question. So my patient, for example, has appendicitis, for example. Should we go to theater or should we give antibiotics? That's one of the questions you'd be asked. And then what does the evidence show behind this? Or in the ED, for example, my patient has pharyngitis, which is a common presentation. Should I give antibiotics or should I not give antibiotics? Similarly, we see a lot of discussions around in the ED, even when COVID came in, about which drugs to give. So that starts off with asking what is wrong with the patient and coming up with a question base in terms of what question do I want to answer? And the question can easily, there's a format, specific format, but it would be, if I give antibiotics, will my patient get better? Or if I do not give antibiotics, will my patient get worse? Or if I do nothing, what would be the outcome of my patient? So once you've asked the right question, the next thing you want to look at is, where is the science? Okay, this is where you have to go look at all the research that's there and try and figure out what is the best management that has been shown out there. So remember, a lot of the evidence, for example, a lot of research papers are done in Western worlds, and we do have a couple also done on our side, but most of the research we'll be looking at papers done in different settings from yours. So normally we'll evaluate all the science and see what has been done out there and that shows benefit. So for example, based on A and B research, giving dexamethasone in patients who meet this criteria with a URTI is beneficial. All right, good. So that's the evidence. So that's what the evidence shows in terms of management of that patient with a URTI. Or for example, in this group of patients, the science has proven that maybe we need to give antibiotics or not go to theater first for appendicitis. So you need to evaluate all the evidences there. But then, so that's actually accessing the information. So going online, getting all the journal papers, or Googling and finding all the best evidence. Then you're looking at the evidence because, again, not all evidence is equal. Not all research is equal. I mean, research conducted in a facility with all the top-notch scientific equipment versus may not necessarily apply in an area where you do not have the resources. So that's the other thing you need to look at. So, and also some factors within the research may definitely not be applicable in your setting. So you need to critique praise the evidence, look at it, make sure it's valid, and then at the end of it all, come back to, this is now the option of figuring out, does this evidence apply to my patient sitting in front of me? And a good way to always think about this is, if the patient sitting in front of me was in that area where they're conducting the research at that particular time, would they have been part of that research? And if the answer is no to that question, then probably that research is not relevant to your patient. If the answer is yes, then your patient is more, fits more within the findings of that particular research. And then the part that not a lot of people do is actually look at, we've treated so we found we asked the question, we found the best evidence, it fits for my patient. I gave my patient the treatment based on that evidence. And then what happens after? Okay, so do we follow up these patients and see, are we getting similar outcomes? And if you all remember the COVID drugs that came into fad and left quickly, because a lot of the time there was some quick evidence that was generated because we were in the middle of a pandemic. We gave the drugs to people, but then when they went down again to evaluate, they realized that in the real world setting and in a long-term follow-up, these drugs are not making a difference. So that after treatment, even if you've done the best, you have the best evidence, the following up your patients to see the outcomes the same as the evidence had suggested becomes important then, because then that helps you to again go back and again tweak the your science again, ask another question, access information, appraise the information, apply the information, audit the impact. So those are the 5 ways. And in clinical practice, yes, for a lot of people, they probably will say it's a lot of work. You need to may not have the time, but I think that's why a lot of these CMEs are important, because then people come on who have potentially reviewed the evidence and then are able to share this from their review. And that's why it's important to always keep tabs of what's going on, because science changes. And that makes the biggest difference between witchcraft and science, because science is dynamic. Science is not fixed. What was practiced 50 years ago potentially is not the same medicine that is currently being practiced today or will be practiced tomorrow. There are a lot of practices that we currently do at the moment that potentially will be outdated in a couple of years. So, and that's the dynamism of science versus witchcraft. So at Foundation, we've been releasing these algorithms now for the last 6 years. The 2022 algorithms are currently out. We just released them. And so how we develop the algorithms again is we look at all the research annually that comes through. So all the research from 2021, and then look at its application in our setting, and then look at the algorithms or develop algorithms for that. But then the algorithms then are used by you healthcare providers on the ground, and the feedback we get from you helps us tweak it to be able to fit our setting. Because again, some of the algorithms, again, we may develop them, but are not necessarily fitting 100% on the ground. So we have this cycle annually where we actually then look at all the science, evaluate the science, look at the algorithms, update them, and then get all the feedback from you from the previous year, and then put them on the algorithm. So what we're going to go through is look at some of the science and some of the best practices, and I'll share the references for this. So for those who are academic enough, can go back and look at the different reference papers. But we've done that. We've done these parts. What's wrong with the patient? We've done the science. We've looked at the options best, okay? And from your feedback, then we look at the audit. The audit for us is not necessarily directly patient, but is the end user's feedback that helps us then tweak the algorithms. So why algorithms? Why are we very stuck on algorithms? In emergency care, algorithms are very important to us. Remember, for us, when a patient comes to the ED, they are pretty much passing by. If you're in a good ED, their turnaround time would be like 4 hours, but that could be some 6 hours. But within that period of time, you must have managed the acute problem, figure out what's going on, and treated them. And they go. Once they leave the door, they've gone. And so you don't have the luxury of saying, oh, I've just remembered something. So the algorithms actually are quite helpful for us. In the sense that number one, evidence-based. So we look at developing the best possible evidence on the ground and have this then applied in the algorithm. So then we are all practicing a standard way of management, which is based on science, okay? To be honest, it doesn't make sense how, if I have a heart attack, if I go to hospital A, hospital B, hospital C, hospital D, I will receive 4 different treatments for the same condition. That means there's no 4 different sciences. There's just one way of managing heart attacks. Well, there's the best way, and then there are potential alternatives. But theoretically, well, from a perspective of science, a heart attack should be managed in a similar fashion across board. So, and this goes across to all the medical conditions. And the idea behind even the algorithms is to reduce the variation that we get on the ground, where healthcare people are practicing different medicines, yet as scientists, we should all be reading from the same science script. So the other thing is algorithms help conserve resources, allow here to save money. So a lot of tests are unnecessary. There's a campaign that went out earlier from the emergency across actually all the specialties, choosing wisely, because a lot of studies have shown that we order unnecessary tests a lot of times, and tests cost money. And so by ensuring that we are standardizing the test to basically what the evidence has shown to be useful, then we reduce the cost for the patient in terms of tests and also even indications, things like admission, treatment for the patient. There was a lot of, during COVID time, there was a lot of over-the-counter therapeutics, I think that's the word I'll use, that had no evidence, and people spend a lot of money, and a lot of pharmacists are actually quite happy. But there was no evidence behind that. So while one group was making money, one group was losing money. Of course, the algorithms reduce confusion, and people don't have to guess what's the next step for the patient. Whether it's the nurses or another healthcare provider, we are on the same page in terms of the management of a patient. And we're on the same page because we are all reading from the same science. We're all looking at the best evidence available. Of course, it helps reduce errors, especially use of algorithms. Then we also have a reference point for our management, and we use this a lot where I work because errors are costly. Errors are costly to the patient, costly to you as a healthcare provider, costly to institutions. And by reducing errors, and I've been in a few meetings where institutions are being asked about some management, and they have to, we're getting to a point where, okay, at this particular meeting, they're asking, show us what are you using to treat the patient? So what's your reference point for the management of patients? So that helps in terms of reducing errors. Of course, you all work as a team using algorithms, and then the idea is to have a consistent, workable approach to the management of patients. All right, so at this point, I'll probably go through some of the algorithms, looking at what the science is, but I think in between, if any questions, please remember you can just touch on the chat. I'll happily add them in between. But at this point, we'll look at some of we'll look at the algorithms. So this is a new version, 2022, and we've made it as, what can I say, as digital as possible to involve different modalities. So there are active links, for example. If I click that, I'll go to the app. So there's an app that has the algorithms. The algorithms will be updated on the app, on the casualty app a bit later, probably by the end of the month. So that's pending. We have a link to additional notes if you want additional notes. There's a whole YouTube channel we've dedicated that shows you the videos of how to do a lot of the procedures that we've put in the algorithm, and I'll show you some of that. And to be honest, as a healthcare provider, you must have it. If you work in the front line, you must have MD Calc on your phone. So MD Calc, Casualty app, I'm sure you all have YouTube, are some of the apps that we recommend for you to have because they help you calculate a lot of things, and I'll show you how that works. So let's look at some of the new things potentially on the algorithm. So triage is core to every emergency department. That's how we prioritize patients based on their acuity, and also avoid patients dying on queue or patients dying before being seen by the healthcare provider, and also just the confusion that may come in with multiple patients coming in. Last year, the WHO, International Red Cross, and Médecins Sans Frontières came up with a 3-level triage system, which is quite cool. And we put this here for you. So it breaks down into whether you're red, yellow, or green. And importantly is, if you're running an ED, you must have this triage. You must have a triage process in place, and you must explain the triage process to your clients or people waiting in the waiting area. I think that's the biggest complaint we have wherever I work is waiting time. Everyone is in a rush, even when they're not critically ill. So if they don't understand your triage system, then it becomes a challenge and you get a lot of noise. So there's an adult, this is the adult version, there's a pediatric version involved. And so they're broken down into red risk criteria. If you don't have any of this, then you have yellow risk criteria. If you none of that, then based on your vital signs, if your vital signs are abnormal, then you upgraded into, you move to the next triage level. If not, then you're just green. And then they look at things like general trauma, road traffic accident, trauma criteria, the signs of respiratory distress, poisons, burns, threatened limb. So quite comprehensive and really impressive work. And I know it's been tested So it's been tested and validated in some Asian countries, so the research just came out. So I think it's one of the things that will probably be implemented slowly by the WHO as we move along across the country. So that's quite good. So we've not really had a standardized triage criteria across here. We've all adapted from different areas. So it's the first one I'm seeing that the WHO is coming up with, which is quite good. So cardiac arrest, not much has changed per se, but just to highlight where the science really emphasizes. So number one, things like giving adrenaline. If you note, for example, in a shockable rhythm, patients who have ventricular fibrillation or pulses VTAC, adrenaline is given after 2 shocks, okay? So there's good science behind this that shows that giving adrenaline early is harmful to your patient. The evidence for adrenaline is it allows you, there's a return of spontaneous circulation, but there's no evidence for in terms of long-term survival. There's some that have shown that some survival to hospital discharge is improved, but in terms of neurological outcome, because the key scientific endpoint for from a resuscitation perspective is good neurological outcome. For so far, there's no evidence that adrenaline helps improve survival to hospital discharge with good neurological outcome. But the science has shown for sure, if you're giving adrenaline too early in your shockable rhythms, it's harmful to your patient. Ideally, you should be given at least 2 shocks, and then you should give adrenaline after that, and then, of course, spaced every 3 to 5 minutes. So avoid giving adrenaline before your 2 shocks. Now, on the flip side, for non-shockable rhythms, the sooner you give adrenaline, the better. Okay, so this one, the science is very clear that the sooner you give adrenaline to the patient, then the outcomes in terms of, again, return of spontaneous circulation. Non-neurological outcomes, so return of spontaneous circulation is much better as soon as you give the patient adrenaline, once you give the patient adrenaline early. So that would be the science behind that. So we're looking at post-cardiac arrest care. So one thing that has definitely changed is we are no longer cooling patients. The science has shown there's no real evidence of freezing your patient off. They just say you need to maintain, pretty much avoid fever, keep your temperatures below 36. So 32 to 36 for at least 24 hours, do not cool them down completely. So we moved from hypothermia at some point where we're keeping a patient's temperature less than 32 degrees. Then we moved to 32, 34. Then we moved to 32, 36. And then now they're saying just avoid fever. So there's good science behind that. Just avoid fever for at least 72 hours after ROSC, okay? That's a key thing. So for those facilities that were wondering about their resuscitation outcomes and whether to start looking for devices, of course, on this side of the world, no one really looks for devices, we can't afford them. Now we don't necessarily need to look for some of these cooling devices. We just need to keep a patient's temperature below 37 for the next 72 hours. Nothing much in the maternal cardiac arrest, neonatal arrest, pretty much the same. Intubation, again, not much in terms of changes. So what we've put here, for example, is, I'll just share this with you. So to help you, let me share that. So with the links, we've created playlists that allow you to understand oxygen therapy, airway management. So it's a good video, airway management by the AHA, so airway preparation, anatomy of the AT tube, preparing with a bougie, things like which drugs to use, the next videos on which drugs to use, airway anatomy for those who've never intubated and want to see how intubation works. The next video now, intubation tips and tricks, and then issues of airway complications. So there's a nice list of videos you can watch, and it goes all the way until how to mechanically ventilate patients. So we've looked at some of these videos and selected the ones that we feel that are well done and self-explanatory for someone who's keen to learn how to get some of these videos done, how to get some of these procedures, and also understand the dynamics behind this. So anywhere you see watch video on our YouTube channel, it's a playlist linked that allows you to then learn more information on that. Again, so intubation, not much. Key thing is you need to know what you're doing. This is always a good algorithm. I think a lot of people die not because you are attempting intubation, is they die because someone didn't know when to stop attempting intubation, which is one of the key things that people understand is if you can't get the tube in, it's fine. You can always bag and reduces issues of mortality during intubation. So again, so there's that there. Soft copy of the algorithms are freely downloadable on the website. They're free. Just go, I'll share the link with you from our website. You can download them for free. Okay, so let's see what else. So again, there's a guide on mechanical ventilation, and you've seen where the videos are, so you can always watch those videos. Anaphylaxis, I think the key science behind this is giving adrenaline as soon as possible. Now, there's always a confusion because people always confuse allergic reactions to anaphylaxis and end up giving adrenaline for allergic reactions, which are not necessarily required. So there is diagnostic criteria for anaphylaxis. So whether you have mucocutaneous signs, and one of these is respiratory compromise, hypertension, syncope, or rapid onset of two of the following: mucocutaneous sign, respiratory compromise, hypertension, persistent GI symptoms, or just hypotension on its own after exposure. So any one of the following three criteria then gives you a diagnosis of anaphylaxis. So interesting enough, what's there? Adrenaline, and more adrenaline, that's the treatment for anaphylaxis. Now, one thing you will note here, no steroids and no antihistamines, okay? So there's no much science behind that. So and again, remember, there's a reference at the bottom or at the end of the document, there are references. So anyone wants to go read the research. So steroids, antihistamines have not shown, you can give some antihistamines maybe for some symptomatic effects, but in terms of managing anaphylaxis, there's no real evidence behind the use of steroids and antihistamines. It's adrenaline. And then, of course, then there's clear criteria when to admit the patient for observation and potentially send them home. Okay, asthma, GINA guidelines. GINA is Global Initiative, something, national asthma. They come out with guidelines every year. And these are really good guidelines, so that's where we normally just pick them up from. And of course, management of asthmatics is nebulization, steroids as soon as possible. And then if you have failed nebulization, then you give magnesium, 2 grams. So, and then you keep reassessing your patient. And then ideally you should be managing asthmatics with peak flow. So this is where MD Calc comes in. So MD Calc, which is available on the phone or even available on the internet. So if I was to click that button, then I'd go to, let's see, MD Calc should open. There we go. So MD Calc, I'm able to use. The good thing about the MD Calc, you're able to use it as a calculator. It gives you the evidence behind it. Remember, everything is about evidence. So the evidence behind the calculator and next steps. So it even has additional algorithms linked to it. And that's why we like Refined to MedCalc, because it has a lot of the calculation. So you don't necessarily need to know any of this. With modern technology, honestly, you don't need to know anything in your head. You just need to have a smartphone, or at least a phone with access to the internet. I know some areas in rural areas do not have nebulization, so that's for them. We still have adrenaline on the guide, and there's actually good science behind adrenaline, good evidence behind that. Epistaxis is badly managed a lot. So part of why these topics are on these algorithms is based for us on the ground, what we see, which patients are we seeing in the emergency department a lot, and which patients are being mismanaged a lot. And so the same way I was talking about evidence-based medicine is we are seeing patients. So we see a lot of epistaxis and everyone is doing their own funny thing, and none of it is evidence-based. So we go back and then come up with guidelines based on the evidence. Then we put it on the ground and see how it works, and then standardize that Epistaxis, yes, how to pack a nose. I've seen people pack, but this is commercial packing, so you may need to be in a fancy area to put a commercial pack. But there's a step-by-step. Most patients, honestly, do not get beyond this first box here. The key thing, and let me just highlight this. The key thing is, of course, if you're the first thing you ask your patient to blow their nose. Blow their nose, remove any clots, and spray the nares with oxymetazoline if you have. Then you have no patient, I can tell you for sure, no patient will squeeze their nose continuously for 5 minutes. They will always let go. And so that's why it's important. So there's this fancy clamp that you can make. Essentially, you need tongue depressors. You put a bit of tape around there, and then it clamps their nose shut. Then that way you're sure that your patient is not going to release, and you need to keep it there for 10 minutes. Most of the time you do this with a nice tight clamp, clamp their nose shut. 10 minutes later, you come back, the bleeding is stopped. Okay, of course, there are different patients, and sometimes it's a posterior, or sometimes continuous, but a good number of patients do not go beyond that point. So you don't need to poke things in there, but the key thing, have them blow their nose and then clamp their nose shut for 10 minutes, okay? And then don't have them lean back, because then they'll throw up and be swallowing blood, and have them lean forward and spit out if they need to. Key thing, this is again from the science, do not prescribe antihypertensives. It is the epistaxis that is it's the anxiety associated with the epistaxis that is making the patient's nose bleed. It is not the hypertension that is making the patient's nose bleed, okay? So a lot of patients will end up with some, to be honest, if you ever are sitting in an ED and you're giving a patient stat antihypertensives, you're doing something wrong. There is no science, okay? And for those who do it, maybe that would be my call to you. Go and find the evidence, if there's any, of giving stat antihypertensives in the ED. If there's an indication, and we'll discuss some of this down here, if there's an indication for antihypertensive, it's usually IV, never oral at all. There's no indication for oral antihypertensives in the emergency department. And so do not worry about the blood pressure in the epistax. Control the epistaxis, the blood pressure will be more or less controlled. And then, so all those asking about the soft copy, I'll just share the link on the chat, and then you can download it from the website directly. So there's that epistaxis. So chest pain and being able to diagnose heart attacks is a big thing with the surge of non-communicable diseases. There's a ton of heart attacks, and heart attacks not managed well end up in heart failure, and then it's just a spiral all the way down. So being able to diagnose what is an ACS for patient having a heart attack is key. And we've then gone ahead and put in ECG changes that should be looking out for in time when you get an ECG suggestive of a heart attack. One of the key things that get missed a lot is posterior heart attacks. And that needs to be considered again in patients with ST depressions in V1 to V3 or so. So this goes, so it breaks down your patient into STEMI, non-STEMI, or unstable angina, and then those who have the luxury of drugs. So one of the key things, a lot of patients with having heart attacks would be able to survive in this country if we all started stocking streptokinase potentially. So connected place and all these places are quite expensive, and I know not many facilities would be able to afford them. At some point, I think streptokinase was available, and I think it was definitely not 200,000. I think it was 40,000. Maybe someone in the field would be able to figure that out. I've seen the charts. I'll be able to respond to them after. So yeah, find streptokinase. To manage a heart attack, STEMI at least, you need an ECG machine and streptokinase. These two things, and a clinician, of course, who knows what they're doing, which is you. Exactly. It doesn't need any specialist. If you knows a heart attack on ECG and you have access to kinase, you potentially save a lot of lives, and just cardiac monitors and the rest. The non-STEMI patients, unstable angina, there's a whole workup to it. Not all of them need to be admitted, but it's quite as you can see, there are many caveats, like do this, if this is this, do this, if this is this, do this. Because remember, we can't just say, if we think it's STEMI, admit all patients, okay? There are costs involved. So you need to be able to figure out who needs to be admitted, who needs to go home. And that's a cost-saving part of having algorithms. Bradycardia, tachycardia. So we've gone through the algorithm, and we have, this is actually, it's one of the more or less, well, semi-recent, but the science behind management of SVTs. Let me see if I can show that.
I'm Andy Applebaum. I'm the Chief Investigator for the REVERT study. I'm also a consultant at the Royal Devon and Exeter Hospital in the southwest of England. Hello there. Hi. I see from your heart tracing that you've got a condition called SVT. The REVERT trial was a randomised controlled trial to look at a method of modifying the Valsalva manoeuvre for the treatment of SVT. Asked you just to get a good seal around that with your mouth and blow hard enough to make the needle reach the top. Modification was designed to increase venous return during the relaxation phase of the manoeuvre and involved laying the patient flat and lifting their legs in the air at the end of the strain phase. Overall, we found that patients that were randomised to the standard manoeuvre, only 17% of patients were cardioverted to sinus rhythm, whereas for the modified technique, 43% of patients returned to sinus rhythm. You're doing really well. It really does demonstrate marked improvement with the modified technique. And I think we should consider using that as a standard approach to the initial treatment of this condition. 5, 4, 3, 2, 1, and just completely relax. Lift your legs up in the air. So we used a blood pressure manometer that was modified for the trial, and that can be done in emergency departments. But in other practice or usual practice, a 10 ml syringe blown just hard enough to start moving the plunger, we believe gives a similar sort of pressure. Right. So you ready? Mm-hmm. And ready, steady, blow. And the benefit of that is that patients can use this at home and outside of the hospital, because it's a condition that can recur, and that gives the patient some control, and may mean that patients don't need to come to hospital in the first place. Okay, and we'll sit you back up now. Okay, you feeling okay?
Yeah. Right. Okay. So simple procedures that manages, which is a good number of patients, that works. And it's quite nice because it's like you've done magic in the emergency department. I know common the procedures, cardioversion and transcutaneous spacing are normally a challenge, and we're actually working to make our own videos on this. But you can actually find very good videos on how to do transcutaneous spacing, and we've sent the link there. Everyone needs to know how to do transcutaneous spacing if you're working in the ED, how to troubleshoot, how to transfer the patient, so all that, and then also synchronize cardioversion. So we've included the procedures that are commonly done and the steps that people need to do. I know everyone does BLS, ACLS, and then forgets everything after that. So the algorithms, and there's a step-by-step guide how to cardiovert a patient, how to pace a patient, that allows you then to manage patients. All right, PE is also quite a lot, and there's a whole criteria. US criteria came out maybe a year or two. For those who are still at WellScore, and I don't know which other one was there before. So 2 criteria, and that's where again the MD Calc helps you. It has a years criteria, it has a pulmonary embolus rule out criteria. A lot of patients down this line then will not have a PE, they do not need imaging. Those who do D-dimers, which is an issue, if you ask me. So a lot of patients do not need a D-dimer. Let's start from there. So if your patients, for example, you look at years criteria, there's clinical signs of DVT, no. Hemoptysis, no. PE, most likely diagnosis, most of the time you're like, yeah, so it's not likely, yeah. So if your patient is hemodynamically stable, low probability of PE, and no years criteria, there's the PARC rules. The PARC rule helps to send patients home, okay? So if your patient doesn't meet any of these criteria, then they're good to go home. They're not more than 49 years of age, they're not running a Turkey, SATs above 95 on room air, no history of hemoptysis, they're not on estrogen, no previous diagnosis of DVT, no recent surgery or trauma, or need to be intubated or hospitalized in the last 4 weeks. And then, of course, they don't have a DVT on top of it. If your patient doesn't meet all this, and goes down, then they go home. For those who work in facilities, you know how much a CTPA costs, not to mention the radiation involved and the contrast and the radiation involved. So a lot of your patients can be saved. And there's one thing I always say, if all the CTPAs you order are negative, you need to check the science, okay? And this cuts across all your tests. If you think about it, and all the tests you keep ordering are always negative, then you need to evaluate your practice, because if all your tests are negative, then you either ordering too many tests, or your test is negative to rule or something. So most of the time, if you're ordering tests, a good chunk of your tests should be coming back positive, not 99.9% negative tests. Okay, because then so that's where the science now comes in hand in terms of telling you which tests are important and when to order them. Like for this one, we'll now tell you when to order D-dimer or not, or when to order CP or not. Hypertension, I don't think we can emphasize this enough. There is no evidence of giving oral antihypertensive to lower the blood pressure in the ED. There's none at all, none, zero, does not exist, okay? This is a practice that started at some point and has been handed over to healthcare providers without any science, okay? Has risk of potential harm in terms of hypoperfusing your organs because of the rapid drop in your blood pressure. And so that needs something that, again, do no harm. So again, if anyone has any evidence that giving oral antihypertensives, or actually any evidence that someone should initiate emergency oral antihypertensive in the ED, please share that. It'd be nice for us to really know. The key thing about any patient having a hypertension is you want to figure out if they're having an emergency, so whether it's a neurological, cardiovascular, or other kind of emergency, and then pretty much then go down the algorithm and initiate treatment. So the other things like see page 17, so if we go here, where am I? Just so I don't get lost on 16. Again, if you click any of this, it takes you immediately to 17. I can go back to hypertension, right? Just like that. So there's a word to it. The PDF is linked. So you're able to move within the PDF as quickly as you need to and gather as much info. So like now I need to go from here. I need to go to the guidelines. This one's I think the JNC8 is the last one. They've not updated this, and gives you guidelines on treatment for hypertension with drugs to give. There's a risk calculator, the SVCD calculator, if you need one. Again, MD Calc will be able to link you that. And then what treatment options are available. And the drugs, dosages, that's captured there. So for patients who have a hypertensive emergency, meaning they have hypertension and have end organ damage, so they're neurological, cardiovascular, kidney, or blood, then you come in here. And you can see for here, there are, if it's encephalopathy, then maybe you're reducing them immediately. But for a lot of the others, they reduce them over a prolonged period of time, not start. That's why I said, if you're reducing blood pressure in the ED, it's a patient who's having a hypertensive emergency, and most of the time you're giving them an IV medication, not oral medication. And here are the infusions for the different drugs that you may need to give at this point: labetalol, esmolol, hydrazine, nitroglycerin. None of them is nifedipine or amlodipine or any other pins that get given in the ED. You should not be giving anyone such antihypertensives orally. Stroke identification is important. A lot of this is new. We've had to include posterior circulation strokes because a lot of patients are being missed. Patients coming complaining just of dizziness. Dizziness, inability to walk, and most of you will just call it vertigo, but it's not vertigo. A good number of them are having strokes, especially they meet the age group. And note for these patients, again, you need to order an MRI, not a CT, because the CT does not image the posterior circulation area. So you could send for CT will be normal, send the patient home meanwhile they're having a stroke. So there's a whole video here of how to diagnose posterior circulation stroke. You can watch that. And then, so this is for those who have the fancy drugs and the fancy protocols when to give fibrinolytic. Neurologists, neurosurgeons now involved because of thrombectomy on in high-end areas. But again, also shows you when should you do a CT, when should you do an MRI, and indications for that. So this, just a comment. So these are complete algorithms. We have created a similar set of algorithms for low resource settings. I'm going to show those ones quickly after this, so that even in low resource settings, it has clear guidelines. What's your next step? So we'll not, if you're in the middle of some part of the rural Kenya, we'll not be asking you to order an MRI. Okay, the protocols give you clear guidance what to do next to ensure safe passage of the patient to the next level of care. I'll probably use a stroke one to illustrate that in the next. Fibrinolysis, so TIAs, so there's a ton of them. Seizures, yes, how to manage status epilepticus, what is status epilepticus, what drugs to give. So that's all captured here. Syncope, yes, we have a lot of syncope, yes. So looking at syncope, again, not every patient who faints needs to be admitted, but we also need to identify safely how to discharge patients who have had a syncopal episode. And so this guideline is there to quickly pick up. We use the San Francisco syncope rule. I know there's a new one, the Canadian syncope rule. I think it's been validated and potentially maybe in the next algorithms you'll see it move. You'll see us move to that as the science changes. And so yes, and again, it's available on MDCalc if you need to, and then who to consult a physician for and who to discharge home. So because of the dizziness problem we've seen a lot on the ground, we've created, this is a new one, there wasn't there in the last year's algorithm, how to manage vertigo, okay? And be able to pick up peripheral vertigo, central vertigo. This is a bad one. This one is the easy one to deal with. And so it goes through and shows you how to do an Epley's maneuver for those who don't know how to do an Epley's maneuver. And these are the patients who then probably end up with a posterior stroke, the central vertigo. So that's been necessitated by, yes, feedback from the ground where people are not very, well, a lot of posterior strokes have been missed, yes. Trauma, of course, it's always nice to have trauma, and we actually have a nice school. In fact, this is probably one we can quickly show. Let me see how. So how to insert how to do sorry, let me just share that. So how to decompress a tension pneumothorax, how to place a chest tube, how to insert a chest tube for trauma, how to insert, secure a chest tube. Yes, then you don't have your chest tube falling off in your emergency department. Right now, we're using picture catheters for small pneumothoraces, and yeah, which are potentially not traumatic, but even now there's good evidence for some traumatic picture catheter placement. So, and again, so this is a whole playlist that you can watch and see everything about chest tube placement. Let's see, what else is there? Okay, so that's trauma, tranexamic acid, and how to manage severe bleeding, whether it's in the head and neck. So you can see scalp, epistaxis, post-tonsillectomy, trauma, bleeding, hemoptysis, hematemesis, intracranial bleeding, obstetrics, pediatric kind of bleeding, and then trauma team activation. So if you're a major facility, you should have a trauma team. And this can be something that you can develop within the team, within the hospital, just to know who to call and when to call them. And there's criteria for that. C-spine clearance, not everyone needs a C-spine collar. Some can be, not everyone needs to be given a C-spine collar. There's clear criteria to actually not need a C-spine collar. We waste a lot of collars. Again, similar, if you go back to your practice, if you're putting C-collars on a lot of patients and then you end up throwing them away, especially if you're in private, or removing them immediately, then you need to evaluate your assessment of your patients, whether they need a collar or not. And there's Canadian and excess spine rules that help you to do that. So trauma brain injury, this is when not to do, because this other thing is not everyone who's hit their head needs a CT head. There's clear indications. So there's a rule, there's a calculator. So only those who need CT heads, open or depressed skull fracture, features of basal skull fractures, more than 2 episodes of vomiting, more than 65, patient has retrograde amnesia, more than 30 minutes, and then dangerous mechanism, fall from a height, you've been hit by a vehicle, you've been thrown out of a vehicle, or you have a bleeding disorder. Not everyone who bumps their head following anything needs CT. And this again, so the Canadian CT rule has already been validated with science, and you can read all that. Actually, MD-Calc will give you the science behind the CT head rule. And then, of course, discharge instructions. So we always say, well, go home, come back if you're sick. So there's a whole discharge chart that you can print out for your department. So all minor head injuries, get the discharge chart and go home. The good thing is here, you can put your phone number in case they need to call you. Yes, so we've gone through bites. So bites, rabies, when to give antivenom. Sorry, not antivenom, anti-rabies. Again, not everyone who's been bitten by a dog needs to be given anti-rabies vaccine. So there is indication when to suture, when not to suture. We've got snakes for you, for those who are anywhere near snakes. And so these are the most common snakes across Kenya. In case someone took a picture or brought them with them, and you have access to, you can do a comparison. Preferably don't have them bring the snakes. No, it's not a good idea. What to do with snake bites? And there's actually a link to Bioken Kenya. They make antivenom, and there's a phone number for you if you want to call them. They're quite good, and you'll be able to access antivenom. But again, not everyone needs antivenom. We have clear indications here about who needs antivenom, who doesn't need antivenom. That's, yes, and how to give the antivenom. There's burns resuscitation, post-rape care, and we've aligned this with the national guidelines. So we've got a lot of gender-based violence, especially with the pandemic. There's a lot of GBV that was happening. And you should check out the national guidelines, but we've made a nice clear flow chart as per the national guidelines on management of rape cases. A lot of the ED is one of the places where if the management is not done well, then the perpetrators potentially go free because of lack of evidence and lack of proper documentation. So we are at the forefront of managing that. Hypoglycemia, decay, yes. So there's tons. I'm just saying we have 3 minutes to the end of this. I think what I'll show you, so there's antibiotics guidelines, there's suicide risk assessment and homicidal evaluation, mental health becoming a big issue now, suicide prevention interventions, management of the severely agitated violent patient, dyspepsia. Dyspepsia specifically, indications for stool H. pylori. Not every person with dyspepsia needs H. pylori. I think the amount of stool that sits in our labs is impressive when you're all looking for H. pylori. So there's clear guidelines. This is, again, evidence-based. What are the indications for H. pylori testing? Not everyone needs to be H. pylori tested. I think we can reduce the amount of poop that we send to the lab. But maybe on the last page, I'll show you. So on the side here, again, is a nice it had bookmark, so you can actually checklist, reference. So all, as you can see, here are all the papers that we've evaluated to come up with this guideline. So if it's algorithm number 33, there is a scientific paper behind, and you can click on that, open the paper and read things like, I can say suicide prevention, consensus guidelines for emergency department, suicide prevention resource center and managing suicide patients. And then, of course, this is management of dyspepsia by Gastro, this was 2019. So we've put for you the reference for you to be able to go and counter check. And again, if of course there is new evidence coming in, then this changes periodically, and we have to update that. These are specific for rural settings, and their role from the perspective that we've removed. So I know someone was asking about hypertension. So hypertensive emergencies, as you can see, this one will tell you which drugs to give, but if you come here in the algorithm, emergencies algorithm, if you have access to the drugs, yes, you need to give the same drugs. But we put the drug infusion. Let me see if I can get one that chest pain. So you can see, for example, chest pain. ends differently here. Consult a cardiologist physician, consider immediately transfer to an appropriate facility. So we've removed some of the extensive, they're accessible if you want them. I mean, they're still, both are freely available, but for a rural setting, for example, if you are looking at pulmonary embolism, again, we'll ask you to consult a consultant, but D-dimers are now becoming more frequently available on the ground. If we look at the good thing, the rural one actually has adult and pediatric cardiac arrest algorithm combined into one, so it captures also pediatric cardiac arrest. And then let me see which ones would have major differences. So a lot of them don't necessarily have that major differences because all these drugs are available. A lot of it is just plain straightforward drugs. But there are, let's see, this is a DKA protocol. Yes, so if, for example, in the complete algorithm, we're using infusions for the management of DKA. In the rural algorithms, we're using subcutaneous. And there's, again, very good evidence behind the use of subcutaneous insulin for the management of DKA. So when you don't have an infusion pump, you can still actually properly manage the patient using subcutaneous insulin. So essentially, the question is, as a healthcare provider, you need to figure out which side of this divide you lie. Are you practicing science and latest evidence-based medicine, or are you on the witchcraft perspective? Yeah, that's for me would be the take-home message. There's freely available guidelines. I mean, our guidelines are not comprehensive by any means, and of course, it's always good when you find your own evidence. And it will always be good if you've used the algorithms and you have specific feedback for us, which we can then find additional evidence. We want to make sure that we're able to provide you with the best evidence in our setting to help patients and be able to get the same care whether I am in a high-end private hospital or in some emergency department in a county out of Nairobi. No, yeah, do not give sublingual nifedipine. I've answered that one. There is no evidence and it's harmful.